Let's move on to the second case, because I think this is a similar upfront patient, but with a little bit different case.
So this is a patient here, BRCA mutated. Her tumor, she has a BRCA mutation. She has high volume disease, newly diagnosed ovarian cancer. So she's 69 years young, Caucasian. She went to the emergency room, had shortness of breath. She has mild hypertension and diabetes. Everything's medically managed, and she is morbidly obese. She has large volume ascites. CT scan of the chest shows large bilateral pulmonary effusions, but no pulmonary embolism. CT scan shows peritoneal carcinomatosis, as well as bilateral adnexal masses. CA125 is 525. She undergoes a thoracentesis, which is 1,500 cc's, cytology showing high-grade adenocarcinoma, paracentesis, 4,500 cc's, high-grade adenocarcinoma. Core biopsy of the omentum shows a high-grade serous carcinoma. Patient underwent debulking surgery with incomplete cytoreduction, so suboptimal debulked, and she's being anticoagulated. You can see her molecular testing, P53 positive, PAX8 positive, WTI and CX7 positive, as well as a BRCA2 mutation. What are the pros and cons considering deciding whether to add bevacizumab to primary chemotherapy for this patient? I think that we've talked about this in the past. And again,
yeah, I mean, I think this is, you know, you've talked about how you would add it to most. I think this is a population, and I don't want to speak for Chad, but that the two of us were kind of saying, okay, you know, stage 4 bulky disease, this is a population where I would really talk and consider bevacizumab, because I think that's where we get our biggest bang for our buck.
You can talk for me. You.
Yeah.
No, I agree totally.
Would you guys have done a primary debulking? I'm not going to lie to you. It's 4,500 cc's, 1,500 cc's, peritoneal carcinomatosis. I mean, I don't want to criticize. I don't know who did the surgery, but I mean, to me, I think this is somebody that, you know, one size doesn't fit all. And I think that's what we're learning, that, you know, they did a core, had a high-grade serous carcinoma. I don't know. I probably would have treated this patient with neoadjuvant chemotherapy.
Yeah, it was interesting. I was reading through the case, and I thought that's where this case was going. That's where my head was going. So.
Me too. Yeah, I would consider it. I think, you know, we definitely use a lot of laparoscopy to assess these patients to try to determine if there's going to be a fetal laparotomy. But I think, you know, a pretty decent sized pleural effusion, we move more towards neoadjuvant, especially if there's a lot of bulky peritoneal disease as well. So,
yep.
But no judgment.
Yeah, no judgment at all. I did those surgeries, but I think I tried to not do them at this point. So she was treated with carbotaxol and Bev, and she achieved a complete remission, which is great, BRCA mutation. Options for maintenance therapy and what influences the decision at this point. Again, I think Chad had a nice discussion about the NCCN guidelines. I mean, to me, this patient has to be treated, or at least be offered, and I would strongly encourage her to be on some type of maintenance therapy. You know, she was already started on bevacizumab. To me, I probably would have switched maintenance this patient and had her on Bev to get the improved response, and then switched over to olaparib by itself. But based off that presentation at SGO, I'm feeling much more comfortable of just taking and adding bevacizumab with olaparib and doing a payola approach to this patient as well.
Yeah, I mean, I think those are both really viable options. I feel like you've got great benefit to the addition of PARP to Bev in this case. You know, I think that I've always been a little reticent to stop bevacizumab based on, you know, some of the data in ovarian, as well as some other cancer types like colorectal, where there seems to be a kind of a bounce back if you stop it. So I feel like the Paola data give us a nice support for potentially combining both. And then of course, you know, if the patient develops any kind of adverse events or side, you can always back down to, you know, to just the PARP inhibitor if you feel like the combination is just not tolerable. So that's what I would, you know, lean towards at this point.
Yeah, I would agree entirely. I'm reticent to stop Bev once started. I think this is a great patient that Paola allows us with evidence now to treat with the combination. So that I think Shannon described perfectly the way I would approach this.
Yeah, I think the main influence is probably the high volume disease, the pleural effusions, and the ascites, and that, you know, the bevacizumab stage 4 will definitely help with that. And then, would you guys use what combo olaparib Bev for a year, and then olaparib an additional year, or would you go 2 years because, you know, PRIMA used 3 years solo and Paola were more on the 2 years? I'm just curious because I'm a big fan of 3 years because I think 80% of these recurrences occur within the first 3 years. That was my thinking behind some of it, but you know, obviously there are very bright people that are designing these trials. I'm just curious what you guys think about the 2 versus 3 years.
Wow, you're very forward thinking. I don't know that I get that far out in my my mindset, my approach. And this is another situation where I think some of the trials were designed with the endpoints, or where do we draw the line where we have to stop it at some point without a whole lot of science to back up when to do that. So I don't have a fixed approach with when I stop it. I try to follow the trial. If I'm following the guidelines of one trial, I will stick with that for the most part.
Yeah, I've been generally, we haven't gotten there with many patients yet with just the solo 1 data, but I've generally been offering them to stop at 2 years. I think, you know, I'll do something similar with Paula, but with that being said, I have some patients that were on bevacizumab maintenance that when we got to that 15-month time point said, well, Dr. Weston, I really don't want to stop. And I said, okay, you know, so I've got a few patients that have been on it for years and they're tolerating it well. So we just kind of keep going. So, you know, I don't think we're ever really cookie cutter, but, you know, I definitely will offer them the opportunity to stop it at some point.